Welcome to the Dr. Izzy's Medical Podcast channel.
Myelodysplastic syndrome. A myelodysplastic syndrome, MDS, is one of a group of cancers in which immature blood cells in the bone marrow do not mature, so do not become healthy blood cells. Early on, no symptoms typically are seen. Later, symptoms may include feeling tired, shortness of breath, bleeding disorders, anemia, or frequent infections. Some types may develop into acute myeloid leukemia. Risk factors include previous chemotherapy or radiation therapy, exposure to certain chemicals such as tobacco smoke, pesticides, and benzene, and exposure to heavy metals such as mercury or lead. Problems with blood cell formation result in some combination of low red blood cell, platelet, and white blood cell counts. Some types have an increase in immature blood cells, called blasts, in the bone marrow or blood. The types of MDS are based on specific changes in the blood cells and bone marrow. Treatments may include supportive care, drug therapy, and hematopoietic stem cell transplantation. Supportive care may include blood transfusions, medications to increase the making of red blood cells, and antibiotics. Drug therapy may include the medications lenalidomide, antithymocyte globulin, and azacitidine. Certain people can be cured with chemotherapy followed by a stem cell transplant from a donor. Signs and symptoms. Signs and symptoms are nonspecific and generally related to the blood cytopenias. Anemia, chronic tiredness, shortness of breath, chilled sensation, sometimes chest pain. Neutropenia, increased susceptibility to infection. Thrombocytopenia, increased susceptibility to bleeding and ecchymosis, as well as subcutaneous hemorrhaging resulting in purpura or petechiae. Many individuals are asymptomatic, and blood cytopenia or other problems are identified as a part of a routine blood count. Neutropenia, anemia, and thrombocytopenia. Splenomegaly or rarely hepatomegaly. Abnormal granules in cells, abnormal nuclear shape and size. Chromosome abnormality, including chromosomal translocations and abnormal chromosome number. Although some risk exists for developing acute myelogenous leukemia, about 50% of deaths occur as a result of bleeding or infection. However, leukemia that occurs as a result of myelodysplasia is notoriously resistant to treatment. Anemia dominates the early course. Most symptomatic patients complain of the gradual onset of fatigue and weakness, dyspnea, and pallor, but at least half the patients are asymptomatic and their MDS is discovered only incidentally on routine blood counts. Previous chemotherapy or radiation exposure is an important factor in the person's medical history. Fever and weight loss should point to a myeloproliferative rather than myelodysplastic process. Causes. Some people have a history of exposure to chemotherapy or radiation. Workers in some industries with heavy exposure to hydrocarbons such as the petroleum industry have a slightly higher risk of contracting the disease than the general population. Xylene and benzene exposures have been associated with myelodysplasia. Children with Down syndrome are susceptible to MDS, and a family history may indicate a hereditary form of sideroblastic anemia or Fanconi anemia. Diagnosis. The elimination of other causes of cytopenias, along with the dysplastic bone marrow, is required to diagnose a myelodysplastic syndrome, so differentiating MDS from anemia, thrombocytopenia, and leukopenia is important. A typical diagnostic investigation includes R. Full blood count and examination of blood film. The blood film morphology can provide clues about hemolytic anemia, clumping of the platelets leading to spurious thrombocytopenia, or leukemia. Blood tests to eliminate other common causes of cytopenia such as lupus, hepatitis, B12, folate, or other vitamin deficiencies, kidney failure or heart failure, HIV, hemolytic anemia, monoclonal gammopathy. Age-appropriate cancer screening should be considered for all anemic patients. Bone marrow examination by a hematopathologist. This is required to establish the diagnosis since all hematopathologists consider dysplastic marrow the key feature of myelodysplasia. Cytogenetics or chromosomal studies. This is ideally performed on the bone marrow aspirate. Conventional cytogenetics require a fresh specimen since live cells are induced to enter metaphase to allow chromosomes to be seen. Interphase fluorescence in situ hybridization testing, usually ordered together with conventional cytogenetic testing, offers rapid detection of several chromosome abnormalities associated with MDS, including del5q-7, +8 and chromosome 20 deletion. Virtual karyotyping can be done for MDS, which uses computational tools to construct the karyogram from disrupted DNA. Virtual karyotyping does not require cell culture and has a dramatically higher resolution than conventional cytogenetics, but cannot detect balanced translocations. Flow cytometry is helpful to identify blasts, abnormal myeloid maturation, and establish the presence of any lymphoproliferative disorder in the marrow. Testing for copper deficiency should not be overlooked, as it can morphologically resemble MDS in bone marrow biopsies. The features generally used to define an MDS are blood cytopenias, ineffective hematopoiesis, dyserythropoiesis, dysgranulopoiesis, dysmegakaryopoiesis, and increased myeloblasts. On the bone marrow biopsy, high-grade dysplasia may show atypical localization of immature precursors, which are islands of immature precursors cells localized to the center of the intertrabecular space rather than adjacent to the trabeculae or surrounding arterioles. This morphology can be difficult to differentiate from treated leukemia and recovering immature normal marrow elements. Also, topographic alteration of the nucleated erythroid cells can be seen in early myelodysplasia, where normoblasts are seen next to bony trabeculae instead of forming normal interstitially placed erythroid islands. Differential diagnosis. Myelodysplasia is a diagnosis of exclusion and must be made after proper determination of iron stores, vitamin deficiencies, and nutrient deficiencies are ruled out. Also, congenital diseases such as congenital dyserythropoietic anemia have been recognized, Pearson syndrome, which is sideroblastic anemia, and Jordan's anomaly. Vacuolization in all cell lines may be seen in Chanarin-Dorfman syndrome. Aminolevulinic acid enzyme deficiency and other more esoteric enzyme deficiencies are known to give a pseudomyelodysplastic picture in one of the cell lines. However, all three cell lines are never morphologically dysplastic in these entities with the exception of chloramphenicol, arsenic toxicity, and other poisons. All of these conditions are characterized by abnormalities in the production of one or more of the cellular components of blood. Management. The goals of therapy are to control symptoms, improve quality of life, improve overall survival, and decrease progression to AML. The IPSS scoring system can help triage patients for more aggressive treatment as well as help determine the best timing of this therapy. Supportive care with blood products and hematopoietic growth factors, for example erythropoietin, is the mainstay of therapy. The regulatory environment for the use of erythropoietins is evolving, according to a recent U.S. Medicare national coverage determination. However, no comment on the use of hematopoietic growth factors for MDS was made in that document. Agents have been approved by the U.S. Food and Drug Administration for the treatment of MDS. They are: first, 5-azacitidine, 21-month median survival. Second, decitabine, complete response rate reported as high as 43%. A phase I study has shown efficacy in AML when decitabine is combined with valproic acid. Third, lenalidomide, effective in reducing red blood cell transfusion requirement in patients with the chromosome 5q deletion subtype of MDS. Fourth, decitabine, cedazuridine is a fixed-dose combination medication for the treatment of adults with myelodysplastic syndromes and chronic myelomonocytic leukemia. Chemotherapy with the hypomethylating agents 5-azacitidine and decitabine has been shown to decrease blood transfusion requirements and to retard the progression of MDS to AML. Lenalidomide was approved by the FDA in December 2005 only for use in the 5q syndrome. HLA-matched allogeneic stem cell transplantation, particularly in younger and more severely affected patients, offers the potential for curative therapy. The success of bone marrow transplantation has been found to correlate with severity of MDS as determined by the IPSS score, with patients having a more favorable IPSS score tend to have a more favorable outcome with transplantation. If patients receive a stem cell transplant, they can develop a graft-versus-host disease. The evidence is very uncertain about the therapeutic effect of mesenchymal stromal cells to treat graft-versus-host diseases after a stem cell transplantation on the all-cause mortality and complete disappear of chronic acute graft-versus-host diseases. Mesenchymal stromal cells may result in little to no difference in the all-cause mortality, relapse of malignant disease and incidence of acute and chronic graft-versus-host diseases if they are used for prophylactic reasons. Patients that receive a stem cell transplant or a chemotherapy as a treatment might have a higher risk for bleeding and may require platelet transfusions. Physical exercises in addition to the standard treatment for adult patients with hematological malignancies may result in little to no difference in the mortality, in the quality of life and in the physical functioning. These exercises may result in a slight reduction in depression. Furthermore, aerobic physical exercises probably reduce fatigue. The evidence is very uncertain about the effect on anxiety and serious adverse events. Iron levels. Iron overload can develop in MDS as a result of the RBC transfusions, which are a major part of the supportive care for anemic MDS patients. A particular risk exists of delayed engraftment and a need for repeated red cell transfusion following HLA identical allogeneic stem cell transplantation if the recipient is blood type 0 and the stem cell donor, type A. Although the specific therapies patients receive may alleviate the RBC transfusion need in some cases, many MDS patients may not respond to these treatments, thus may develop secondary hemochromatosis due to iron overload from repeated RBC transfusions. Patients requiring relatively large numbers of RBC transfusions can experience the adverse effect of chronic iron overload on their liver, heart, and endocrine functions. The resulting organ dysfunction from transfusional iron overload might be a contributor to increased illness and death in early-stage MDS. For patients requiring many RBC transfusions, serum ferritin levels, number of RBC transfusions received, and associated organ dysfunction in heart, liver, and pancreas, and this should be monitored to determine iron levels. Monitoring serum ferritin may also be useful, aiming to decrease ferritin levels to less than 1,000 micrograms per liter. Currently, 2 iron chelators are available in the U.S., deferoxamine for intravenous use and deferoxamine for oral use. These options now provide potentially useful drugs for treating this iron overload problem. A third chelating agent is available in Europe, deferiprone, for oral use, but is not available in the U.S. Clinical trials in the MDS are ongoing with iron chelating agents to address the question of whether iron chelation alters the natural history of patients with MDS who are transfusion dependent. Reversal of some of the consequences of iron overload in MDS by iron chelation therapy has been shown. Both the MDS Foundation and the National Comprehensive Cancer Network MDS Guidelines panel have recommended that chelation therapy be considered to decrease iron overload in selected MDS patients. Evidence also suggests a potential value exists to iron chelation in patients who will undergo a stem cell transplant.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.